presentation, we are going to discuss disorders of the peripheral nervous system. Neuromuscular disorders are conditions that affect the communication between the nervous system and the muscles. These disorders can involve the motor neurons in the brain or spinal cord, the peripheral nerves, the neuromuscular junction, or the muscles themselves. When any part of this pathway is damaged, the signals that normally tell a muscle to move become weak or completely blocked. As a result, patients experience symptoms like muscle weakness, fatigue, poor coordination, difficulty swallowing, or difficulty breathing, depending on which muscles are affected. Many neuromuscular disorders are chronic and progressive, meaning they worsen over time, and severe cases may eventually compromise the respiratory muscles, leading to complications such as pneumonia or respiratory failure if not properly managed. In this presentation, we will review several of the most common neuromuscular disorders encountered in nursing practice, such as multiple sclerosis, myasthenia gravis, amyotrophic lateral sclerosis, and Guillain-Barré syndrome. Each of these conditions has a very different cause and pattern of progression, but all can result in varying levels of disability and require careful nursing assessment, early recognition of complications, and supportive management. By understanding the characteristics of these disorders, nurses can better anticipate patient needs, recognize early signs of respiratory decline, and participate in patient education and long-term care planning. Multiple sclerosis, commonly called MS, is a chronic progressive disease that primarily affects the central nervous system, which includes the brain, spinal cord, and optic nerves. Please do not be confused by its placement in this section. For some reason, Mississippi is often covered alongside disorders of the peripheral nervous system, even though multiple sclerosis is defined as a disorder of the central nervous system because it enhances understanding of damage to the upper motor neuron versus damage seen to the lower motor neuron, reflex differences, sensory changes, and how each disorder progresses. Multiple sclerosis occurs when the body's immune system mistakenly attacks the myelin sheath, the protective covering around nerve fibers. When myelin is damaged, the electrical signals that normally travel smoothly along the nerves become slowed or completely blocked. This leads to a wide range of neurological symptoms that can come and go or progressively worsen over time. Because multiple sclerosis affects the central nervous system rather than the peripheral nerves or muscles, patients may experience symptoms such as vision changes, numbness or tingling, balance problems, muscle weakness, fatigue, cognitive changes, or difficulties with coordination. The pattern of the disease varies among individuals. Some people have periods of remission and relapse, while others have a steady decline in function. As nurses, it's important to recognize early symptoms and understand that multiple sclerosis is unpredictable, meaning patients often require support with medication administration, mobility assistance, managing fatigue, and preventing complications such as falls, pressure injuries, and infections. Multiple sclerosis does not have a cure, but treatments can slow progression, manage flare-ups, and help patients maintain independence for as long as possible. Let's break this all down. As we begin discussing multiple sclerosis, it's essential to understand what happens to the myelin sheath, because this structure is central to nearly every neurological symptom patients experience. Myelin acts like insulation around an electrical wire, allowing nerve impulses to move quickly, smoothly, and efficiently through the nervous system. Take a moment to look at the image. In the healthy neuron labeled A, the myelin sheath fully intact. This supports normal coordination of movement, sensation, and response. In image B, early demyelination is beginning. Even slight damage to myelin can slow nerve conduction, which is why early multiple sclerosis symptoms are often intermittent, such as tingling, mild weakness, or blurred vision. These symptoms may come and go because the nerve fibers are functioning inconsistently. Image C shows severe myelin disruption. At this point, the protective covering is significantly damaged or completely lost, and the axon underneath may also be injured. When conduction becomes unreliable or blocked, patients can develop major neurological deficits, such as significant muscle weakness, loss of coordination, mobility problems, vision loss, or balance disturbances. This slide helps us visualize multiple sclerosis as a progressive spectrum rather than a sudden event. Understanding how changes in myelin affect nerve signaling helps nurses better interpret flare-ups, monitor changes in patient status, and provide informed support throughout the course of the disease. Why does damage occur to the myelin in MS? In multiple sclerosis, an autoimmune process drives the disease. The immune system, especially T cells and inflammatory mediators, incorrectly targets the myelin sheath as if it were harmful. This triggers inflammation, swelling, and ultimately demyelination within the central nervous system. Over time, repeated cycles of inflammation lead to the formation of sclerotic plaques, which are areas of hardened scar tissue. These plaques interfere with the nerve's ability to send electrical impulses effectively, acting like roadblocks along the nerve pathway. Depending on where these plaques form, patients may experience weakness, sensory disturbances, ataxia, visual changes, bladder dysfunction, or difficulty with coordination. The exact cause of multiple sclerosis is unknown, but research shows it likely results from a mix of genetic susceptibility and environmental triggers. Individuals may have immune-related genes that increase risk, but often need an activating trigger such as a viral infection. Other risk factors include vitamin D deficiency, smoking, low sunlight exposure, and certain geographic regions. Also, multiple sclerosis is also more common in women and typically begins between the ages of 20 and 50. Understanding these mechanisms helps with patient education, early recognition of symptoms, identification of risk factors, and support during relapses. It also explains why multiple sclerosis symptoms can be unpredictable depending on which areas of the central nervous system are affected and the degree of inflammation occurring at a given time. It's important to remember that multiple sclerosis affects each patient differently. The symptoms depend on the location of the demyelinating lesions within the central nervous system. Because these lesions can occur anywhere in the brain or spinal cord, multiple sclerosis can produce a wide range of neurological deficits. Symptoms may develop gradually over weeks to months, or they may appear suddenly during a relapse. Some symptoms may improve during remission, while others become permanent as scar tissue builds up. Common motor symptoms include muscle weakness, spasticity, ataxia, and paralysis in advanced disease. These occur because the central nervous system can no longer send smooth, coordinated signals to the muscles. Sensory symptoms like numbness, tingling, burning sensations, or altered temperature perception result from disrupted pathways in the sensory tracts. Visual symptoms, including blurred vision, diplopia, or double vision, and scotomas, or localized areas of partial or complete vision loss, often reflect inflammation of the optic nerve, known as optic neuritis. Multiple sclerosis also affects speech and swallowing. Patients may develop dysarthria or slurred speech from impaired muscle coordination and dysphagia or difficulty swallowing due to weakened or uncoordinated muscles used in swallowing. Autonomic symptoms are also common. These include bowel and bladder dysfunction such as constipation, urinary retention, or the inability to completely empty the bladder, spastic bladder, or a bladder that contracts too often and too strongly even when not full, uninhibited bladder, or when the brain's control over the bladder is interrupted and leads to urinary urgency, frequency, urge incontinence, and sudden unpredictable voiding, and in some cases, a hypotonic bladder, or a flaccid bladder that cannot contract effectively, leading urinary retention. Sexual dysfunction also occurs in both men and women due to disrupted nerve pathways and psychosocial factors. Fatigue is one of the most significant and disabling symptoms of multiple sclerosis. It may be severe enough to limit mobility and daily functioning, even when muscle strength is relatively preserved. Cognitive and emotional symptoms can include difficulty concentrating, memory changes, mood swings, depression, anger, or euphoria, or an intense feeling of happiness, well-being, excitement, or pleasure. Please note, while euphoria does occur, it is less common. Vestibular symptoms such as vertigo and nystagmus occur when lesions affect balance centers in the brainstem or cerebellum. Remember, vertigo is a false sensation of spinning or movement, and nystagmus is an involuntary, rhythmic back-and-forth movement of the eyes. These symptoms often create major safety risks for patients. Weakness, ataxia, or lack of coordination and control of voluntary muscle movement, visual impairment, dizziness, and sensory loss greatly increase the risk for falls, aspiration injuries, and accidents. As multiple sclerosis progresses, weakness of the diaphragm and intercostal muscles may reduce respiratory function. Patients are at increased risk for pneumonia, and in late stages, respiratory failure may occur. Understanding these symptoms helps nurses anticipate complications, provide safety interventions, and support patients through varying stages of illness. This slide gives us a visual way to remember some of the hallmark signs and symptoms associated with multiple sclerosis and an excellent opportunity to review. Because constipation is a chronic demyelinating disorder of the central nervous system, It can affect nearly every body system depending on where the lesions occur. This illustration summarizes common neurological, visual, sensory, motor, and autonomic symptoms in a way that helps us recall them quickly. Starting at the head, the image includes symptoms such as nystagmus, diplopia, blurred vision, and dysarthria, which all result from demyelination affecting the optic pathways, cerebellum, or brainstem. Optic neuritis is a common early finding in multiple sclerosis and can cause temporary vision loss or significant pain with eye movement. Dysphagia may occur when lesions affect the cranial nerves or brainstem areas responsible for swallowing. Mood and cognitive changes are also included, reflecting the fact that multiple sclerosis can impact memory, concentration, emotional regulation, and decision-making. As we move downward, the illustration highlights motor deficits such as muscle weakness, spasticity, ataxia, and vertigo, which occur when demyelination disrupts coordination and voluntary control of movement. These symptoms increase the risk of falls, injuries, and mobility impairment. Autonomic dysfunction is also depicted, including urinary retention, spastic bladder, and constipation. These issues occur because multiple sclerosis lesions often involve pathways that control bowel and bladder function. Sexual dysfunction can also be present for both men and women, although it is not shown in every diagram. Finally, the slide notes that the disease often begins between the ages of 20 and 40, with women affected more frequently. This visual summary helps unify everything we have discussed about multiple sclerosis so far and emphasizes why comprehensive assessment is essential. When working with patients, nurses must watch for emerging symptoms, identify safety concerns early, and support the patient's independence and quality of life. When caring for patients with multiple sclerosis, an important part of nursing education and patient support is understanding what can trigger a relapse or worsen symptoms. Multiple sclerosis symptoms can fluctuate, and patients may experience periods of remission followed by flare-ups, also called exacerbations. These exacerbations occur when inflammation increases in the central nervous system, causing new symptoms or worsening existing ones. Recognizing common triggers allows nurses to help patients minimize their risk and maintain better symptom control. One major trigger is extreme temperatures, especially heat. Many multiple sclerosis patients experience what's known as Uthoff's phenomenon, where an increase in body temperature due to weather, hot showers, fever, or strenuous activity worsens neurological symptoms temporarily. Extreme cold can also increase stiffness and spasticity. Fatigue is another common trigger. Because fatigue is one of the hallmark symptoms of multiple sclerosis, excessive exertion, lack of rest, or overworking can push the nervous system beyond its limits and worsen symptoms. Infection is a significant and well-known trigger. Even mild infections, such as a urinary tract infection or respiratory illness, can provoke a multiple sclerosis flare because infection increases systemic inflammation. Nurses play a key role in monitoring for signs of infection, encouraging hydration, and ensuring prompt reporting and treatment. Physical and emotional stress can also lead to symptom exacerbation. Stress hormones influence the immune system, and in multiple sclerosis, this can amplify inflammation. Teaching stress reduction strategies like good sleep habits, paced activity, relaxation techniques, and emotional support is essential. Finally, hormonal changes may influence multiple sclerosis activity. Some women experience symptom improvement during pregnancy due to natural immune suppression, followed by increased relapse risk in the postpartum period when the immune system rebounds. Other hormonal changes, such as menopause or menstrual cycle fluctuations, can also impact symptoms. Understanding these triggers helps patients anticipate changes in their condition, modify daily routines, and seek help early when a flare may be starting. Multiple sclerosis does not follow the same course for every patient. Instead, there are distinct patterns of disease progression, each with different expectations for symptoms, relapses, and long-term outcomes. Knowing these patterns helps nurses recognize changes in the patient's condition, anticipate care needs, and provide accurate education and support. The most common form of multiple sclerosis is relapsing remitting multiple sclerosis, or RRMS. This form accounts for about 85% of initial multiple sclerosis diagnoses. In RMS, patients experience relapses, also called flare-ups, or exacerbations, where symptoms become worse or new symptoms appear. These relapses are followed by periods of remission where symptoms partially or completely resolve. Some patients return close to their baseline between attacks, while others may retain mild deficits after each relapse. RRMS is often the stage where disease-modifying medications are most effective. Over time, many patients with RRMS will transition into secondary progressive multiple sclerosis, or SPMS. In SPMS, relapses may still occur, but the key difference is that neurological function gradually worsens between relapses, and symptoms no longer fully resolve. The disease becomes more steadily progressive with increasing disability over time. This stage reflects ongoing nerve damage rather than just myelin inflammation. A smaller group of patients, about 10–15%, are diagnosed from the beginning with primary progressive multiple sclerosis, or PPMS. In PPMS, there are no clear relapses or remissions. Instead, patients experience a steady, continuous worsening of symptoms from the onset. This form tends to affect older individuals at diagnosis and progresses more slowly but more consistently. Because the disease is progressive from the beginning, PPMS is often more challenging to treat, and mobility impairment may appear earlier. Understanding these three progression patterns helps nurses recognize when a patient's condition is changing and reinforces the importance of early symptom detection, mobility monitoring, and safety interventions. It also helps nurses support patient education on treatment goals, prognosis, and ways to maintain independence throughout the disease course. There is no single test that definitively confirms the disease. Instead, multiple sclerosis is diagnosed using a combination of the patient's history, signs and symptoms, neurological examinations, imaging studies, and laboratory tests. This is because multiple sclerosis can mimic many other neurological and autoimmune disorders, so ruling out other possible causes is just as important as finding evidence of demyelination. One of the first steps is the history and physical examination. Providers look for patterns of neurological symptoms that appear over time and affect different parts of the central nervous system. These may include visual disturbances, sensory changes, weakness, or coordination problems. To support the diagnosis, a cerebrospinal fluid analysis may be performed through a lumbar puncture. In multiple sclerosis, the cerebrospinal fluid often shows elevated immunoglobulin G, IgG levels, or the presence of oligoclonal bands, which indicate abnormal immune activity in the central nervous system. The most important diagnostic tool for multiple sclerosis is magnetic resonance imaging, or MRI. MRI allows us to visualize areas of demyelination in the brain and spinal cord. These appear as bright or dark patches called lesions or plaques. MRI can determine both old and new lesions, helping establish the dissemination and time and space criteria needed for diagnosis. Another helpful tool is evoked potential testing, which measures how quickly the brain responds to sensory stimuli such as light, sound, or touch. Delayed responses suggest slowed nerve conduction, which supports the presence of demyelination. Finally, blood tests are used not to diagnose multiple sclerosis, but to rule out other diseases that have similar symptoms. These include Lyme disease, lupus, neuromyelitis optica, formerly DeVick's disease, human immunodeficiency virus or HIV, syphilis, and certain vitamin deficiencies. Because multiple sclerosis symptoms can overlap with so many other conditions, a thorough evaluation is essential. Understanding these tests helps nurses educate patients, prepare them for diagnostic procedures, and support them through what can often be a stressful and confusing process. Multiple sclerosis currently has no cure. However, treatment plays a key role in slowing the progression of the disease, reducing the frequency of relapses, and managing symptoms so patients can maintain the highest possible level of function and independence. These treatments fall into three main categories: treatments that modify the disease, treatments that treat acute relapses, and treatments that help control ongoing symptoms. First, disease-modifying therapies, or DMTs, are medications that aim to decrease inflammation in the central nervous system and slow the progression of multiple sclerosis. These include interferon therapies such as beta-seron and Avonex, as well as newer medications like glatiramer acetate, teriflunomide, Aubagio, dimethyl fumarate, Tecfidera, and monoclonal antibodies such as ocrelizumab, Ocrevus. These medications help reduce the number and severity of relapses, but they can have significant side effects and require careful monitoring. The next group of medications focuses on symptom management. Multiple sclerosis can cause a wide variety of symptoms, so medications are chosen based on what the patient is experiencing. Anticonvulsants such as carbamazepine or duloxetine help with neuropathic pain. Muscle relaxants like baclofen, tizanidine, or diazepam help manage muscle spasms and spasticity. Bladder medications such as oxybutynin or bethanychol treat urinary issues. Antidepressants can help with fatigue or mood symptoms. Because multiple sclerosis symptoms are highly individualized, treatment plans must be tailored to each patient. To treat acute exacerbations or flare-ups, high-dose corticosteroids are commonly used. Steroids reduce inflammation and help shorten the duration of symptoms during an attack. In cases where steroids are ineffective or not tolerated, plasmapheresis may be used. Plasmapheresis works by removing harmful antibodies from the blood that may be contributing to the immune attack on myelin. The next group of medications focuses on symptom management. Multiple sclerosis can cause a wide variety of symptoms, so medications are chosen based on what the patient is experiencing. Anticonvulsants such as carbamazepine or duloxetine help with neuropathic pain. Muscle relaxants like baclofen, tizanidine, or diazepam help manage muscle spasms and spasticity. Bladder medications such as oxybutynin or bethanychol treat urinary issues. Antidepressants can help with fatigue or mood symptoms. Because multiple sclerosis symptoms are highly individualized, treatment plans must be tailored to each patient. Finally, rehabilitation therapies are essential. Physical therapy focuses on strength, mobility, and balance. Occupational therapy helps patients adapt daily activities and the home environment for safety and independence. Speech therapy supports patients who have swallowing or speech difficulties related to multiple sclerosis. Assistive devices such as canes, walkers, wheelchairs, braces, or splints may improve mobility and prevent falls. Rehabilitation is often most beneficial after an exacerbation but remains important throughout the disease course. Nurses play a crucial role in medication monitoring, patient teaching, recognizing side effects, and promoting safety. Encouraging adherence to treatment, supporting patients emotionally, and helping them manage fatigue and mobility limitations greatly improves their quality of life. Plasmapheresis, also called plasma exchange therapy, is a procedure used when patients with multiple sclerosis experience severe relapses that do not respond to high-dose steroids. This therapy works by removing the patient's plasma, the liquid part of the blood, which contains harmful antibodies involved in the immune attack on myelin. The removed plasma is replaced with donor plasma, or a protein solution such as albumin. The goal is to decrease inflammation, reduce circulating autoantibodies, and help stabilize neurological function. As nurses, our role in preparing and monitoring the patient is essential to safety and successful treatment. Before the procedure, patient education is critical. Nurses should make sure the patient understands what the machine looks like, how the procedure works, and how long it will take, usually between 2 and 5 hours. Patients may need arterial or large-bore venous access, so explaining the need for specialized IV sites reduces anxiety. This is also the time to verify medication holds, as certain medications must be paused until after the procedure. Some patients may be given pre-medications to prevent reactions or discomfort. Baseline assessments are extremely important. You should check and document vital signs, weight, and the results of pre-procedure lab work. This includes a complete blood count, platelet count, and clotting studies. Plasmapheresis can affect circulating blood components, so knowing the baseline values helps identify complications early. Since the procedure may cause shifts in volume or clotting factors, the patient's blood type and cross-match should be confirmed in case replacement blood products are required. After the plasmapheresis procedure, careful monitoring continues. Because the therapy temporarily removes plasma volume, patients are at risk for hypovolemia, which may present as dizziness, tachycardia, or hypotension. Another key nursing task is assessing the access site for bleeding, infection, or bruits, especially if a central line was used. Electrolyte imbalances can occur because plasma exchange removes electrolytes along with antibodies, so patients should be monitored for signs of low calcium, low potassium, or muscle cramps. Any abnormalities should be reported immediately and replacement electrolytes administered if ordered. Finally, post-procedure labs must be compared with pre-procedure values to assess for unexpected drops in blood counts or clotting disturbances. By performing thorough assessment and monitoring before and after plasmapheresis, nurses help ensure patient safety and contribute to positive outcomes. Ongoing nursing care and patient self-management strategies help individuals with multiple sclerosis maintain function and prevent exacerbations. Because multiple sclerosis is a chronic, unpredictable disease, patients benefit greatly from structured routines, early symptom works. Under normal conditions, a motor neuron releases acetylcholine, or HEH, into the neuromuscular junction. Acetylcholine travels across the small gap between the nerve ending and the muscle fiber, where it binds to acetylcholine receptors on the muscle. When enough receptors are activated, the muscle contracts. This process allows us to speak, chew, breathe, swallow, and move our arms and legs. In myasthenia gravis, the immune system begins producing antibodies that mistakenly target and destroy these acetylcholine receptors. As the number of functioning receptors decreases, acetylcholine has fewer places to bind. Even though the nerve still releases acetylcholine normally, the muscle cannot receive the signal effectively. This leads to the hallmark symptoms of myasthenia gravis: muscle weakness that worsens with activity and improves with rest. The more a muscle is used, the faster the available receptors become fatigued, causing the weakness to appear progressively worse over time. The diagram highlights this difference. The top image shows a normal neuromuscular junction where acetylcholine receptors are plentiful and able to respond to neurotransmitter release. The lower image shows the damaged receptor sites in myasthenia gravis with fewer receptors available. This is why muscles involved in eye movement, swallowing, facial expression, speech, and breathing are often the first and most significantly affected. Understanding this process helps nurses recognize early signs of myasthenia gravis, such as drooping eyelids, double vision, slurred speech, or difficulty swallowing. It also helps you anticipate changes during activity and identify when a patient may be experiencing worsening weakness or a potential myasthenic crisis. Myasthenia gravis is a chronic autoimmune disorder, meaning the body's immune system mistakenly attacks its own tissues, in this case, the acetylcholine receptors at the neuromuscular junction. Although the exact cause of this autoimmune process is still unknown, several factors have been linked to the development of myasthenia gravis. One major factor involves the thymus gland, which is responsible for training immune cells. In many adults with myasthenia gravis, the thymus remains abnormally large or contains clusters of immune cells that continue to produce antibodies long after they should have stopped. Some patients may even develop thymomas, which are benign tumors of the thymus. This connection explains why thymectomy, the surgical removal of the thymus, is sometimes used as part of myasthenia gravis treatment. Another factor is genetic susceptibility, although myasthenia gravis itself is not directly inherited. Having a family member with an autoimmune disease slightly increases the chance of developing myasthenia gravis. The disorder occurs in all ethnicities and both genders, but onset patterns differ. Women are more commonly affected at younger ages, typically between 20 and 30, while men tend to develop myasthenia gravis later in life, often after age 60. Hormonal differences may help explain these age and gender-related patterns. Myasthenia gravis, the immune system begins producing antibodies that mistakenly target and destroy these acetylcholine receptors. As the number of functioning receptors decreases, acetylcholine has fewer places to bind. Even though the nerve still releases acetylcholine normally, the muscle cannot receive the signal effectively. This leads to the hallmark symptoms of myasthenia gravis: muscle weakness that worsens with activity and improves with rest. The more a muscle is used, the faster the available receptors become fatigued, causing the weakness to appear progressively worse over time. The diagram highlights this difference. The top image shows a normal neuromuscular junction where acetylcholine receptors are plentiful and able to respond to neurotransmitter release. The lower image shows the damaged receptor sites in myasthenia gravis with fewer receptors available. This is why muscles involved in eye movement, swallowing, facial expression, speech, and breathing are often the first and most significantly affected. Understanding this process helps nurses recognize early signs of myasthenia gravis, such as drooping eyelids, double vision, slurred speech, or difficulty swallowing. It also helps you anticipate changes during activity and identify when a patient may be experiencing worsening weakness or a potential myasthenic crisis. Myasthenia gravis is a chronic autoimmune disorder, meaning the body's immune system mistakenly attacks its own tissues, in this case, the acetylcholine receptors at the neuromuscular junction. Although the exact cause of this autoimmune process is still unknown, several factors have been linked to the development of myasthenia gravis. One major factor involves the thymus gland, which is responsible for training immune cells. In many adults with myasthenia gravis, the thymus remains abnormally large or contains clusters of immune cells that continue to produce antibodies long after they should have stopped. Some patients may even develop thymomas, which are benign tumors of the thymus. This connection explains why thymectomy, the surgical removal of the thymus, is sometimes used as part of myasthenia gravis treatment. Another factor is genetic susceptibility, although myasthenia gravis itself is not directly inherited. Having a family member with an autoimmune disease slightly increases the chance of developing myasthenia gravis. The disorder occurs in all ethnicities and both genders, but onset patterns differ. Women are more commonly affected at younger ages, typically between 20 and 30, while men tend to develop myasthenia gravis later in life, often after age 60. Hormonal differences may help explain these age and gender-related patterns. There is also evidence that viral infections may trigger autoimmune activity in individuals who are already genetically predisposed. These infections may activate the immune system in a way that causes immune cells to mistakenly target acetylcholine receptors. Overall, myasthenia gravis likely results from a combination of immune, genetic, hormonal, and environmental factors rather than any single cause. Understanding these influences helps nurses educate patients, anticipate age-related patterns of onset, and support those who may be newly diagnosed or experiencing symptom progression. To better understand the signs and symptoms of myasthenia gravis, it helps to understand that myasthenia gravis affects the communication between nerves and voluntary muscles. Because the number of functioning acetylcholine receptors is reduced, the muscles cannot sustain strong contractions, especially with repeated use. The classic feature of myasthenia gravis is muscle weakness that worsens with activity and improves with rest. This fluctuation is a key diagnostic clue for clinicians and something nurses must watch for in day-to-day assessments. Myasthenia gravis often begins with symptoms involving the eyes and face because these muscles are small and used frequently. One of the earliest signs is ptosis, or drooping of one or both eyelids. Patients may also report diplopia or double vision due to weakness of the muscles that control eye movement. As the weakness progresses, facial expressions may become reduced or mask-like, and patients may experience difficulty smiling, chewing food, or maintaining facial strength during conversation. Weakness of the bulbar muscles, which control speaking and swallowing, leads to symptoms such as slurred speech, difficulty chewing, choking on food, or frequent throat clearing. Over time, the patient's voice may become softer or fade after long periods of talking because the muscles fatigue quickly. Difficulty swallowing is a serious concern as it increases the risk for aspiration and pneumonia. Myasthenia gravis may also affect the respiratory muscles, making breathing difficult, especially during exertion or during an exacerbation. When this weakness becomes severe enough to impair ventilation, the patient is experiencing a myasthenic crisis, which is a medical emergency requiring rapid intervention. Limb weakness is also common, leading to difficulty lifting the arms, climbing stairs, or maintaining balance. Falls may occur due to leg fatigue. Patients with myasthenia gravis go through remissions and exacerbations, similar to multiple sclerosis, but myasthenia gravis is not a progressive neurological disease. Symptoms fluctuate rather than steadily worsen. Exacerbations can be triggered by infections, stress, menstruation, extreme temperatures, illness, pregnancy, electrolyte imbalances, or by medications that interfere with neuromuscular transmission. Understanding these triggers allows nurses to teach patients preventive strategies and identify early signs of worsening weakness. Recognizing these symptoms promptly is critical for maintaining patient safety and preventing complications. This slide provides a visual representation of what happens in myasthenia gravis and helps us connect the physical symptoms we see with the underlying pathophysiology. These types of images helps us review and retain important information. The picture of the child clearly shows ptosis, or drooping of the eyelid, which is one of the most common early signs of myasthenia gravis. This occurs because the muscles that lift the eyelids fatigue quickly when the acetylcholine receptors are damaged. In many patients, myasthenia gravis may start with ocular symptoms before progressing to affect facial, bulbar, limb, or respiratory muscles. The diagram also shows the neuromuscular junction, where the nerve communicates with the muscle. In a healthy neuromuscular junction, the nerve releases acetylcholine, which crosses the synapse and binds to receptor sites on the muscle. When these receptors activate, they open channels that allow sodium ions to enter, generating the electrical change needed to cause a muscle contraction. The lower portion of the slide highlights the key problem in myasthenia gravis. Antibodies block or destroy the acetylcholine receptors. You can see the normal receptor on the left allowing acetylcholine to bind and sodium to enter. On the right, the receptor has been blocked by an antibody. This means that even if acetylcholine is released normally, the muscle cannot respond because the signal never reaches it. As a result, the muscle becomes weak and fatigues quickly. This damage does not affect the nerve itself, only the communication point between the nerve and the muscle. Symptoms fluctuate throughout the day because repeated use of a muscle uses up available receptors, making weakness worse with activity and better with rest. For nurses, it is important to recognize the early physical signs, such as ptosis, difficulty smiling, chewing, or changes in voice, as well as the more serious symptoms like difficulty breathing or swallowing, which may require emergency intervention. This visual can be a helpful reminder that myasthenia gravis is not a problem of the muscle or the nerve, but of the impaired connection between them. Complications of myasthenia gravis focus on the consequences of weakened muscles in areas that are essential for swallowing, breathing, and maintaining an open airway. Because myasthenia gravis affects voluntary muscles, the muscles of the face, mouth, throat, and diaphragm can become fatigued rapidly, especially during illness, stress, or periods of under or over medication. This means that patients with myasthenia gravis are at increased risk for several potentially life-threatening complications. One of the most serious risks is aspiration, which occurs when food, liquid, or saliva enters the airway instead of the esophagus. Weakness of the swallowing muscles, poor cough effort, and fatigue during eating all contribute to this. Frequent aspiration can lead to aspiration pneumonia, and in MG, respiratory infections and respiratory failure are the leading causes of death. Nurses play a vital role in monitoring swallowing, assessing for coughing during meals, and reporting changes in speech or drooling that could signal bulbar muscle fatigue. A major complication is myasthenic crisis, which happens when muscle weakness becomes severe enough to impair breathing. This often results from under-medication, infection, stress, or other triggers. Signs may begin with increased difficulty swallowing, speaking, or holding the head upright, but the most critical concern is weakening of the respiratory muscles. These patients need immediate medical treatment, often in an intensive care setting, and may require ventilation. On the opposite end of the spectrum is cholinergic crisis, which occurs from over-medication with acetylcholinesterase inhibitors. These medications are designed to increase the amount of acetylcholine available at the neuromuscular junction, but too much can overwhelm the system. Early signs include worsening muscle weakness, drooling, sweating, abdominal cramping, and increased bronchial secretions. Both myasthenic crisis and cholinergic crisis involve respiratory distress and require emergency evaluation. Distinguishing between the two is essential because treatment differs. Lastly, certain medications can trigger myasthenia gravis exacerbations by interfering with neuromuscular transmission. These include some antibiotics such as aminoglycosides, certain cardiac drugs like beta blockers and calcium channel blockers, magnesium-containing medications, botulinum toxin, and neuromuscular blocking agents used in surgery. As nurses, we must be aware of these high-risk medications, ensure they are avoided or used cautiously, and report any sudden change in muscle strength or breathing. Understanding these complications helps us anticipate problems early, assist patients with safe swallowing practices, monitor breathing closely, and respond quickly to changes that may indicate a life-threatening crisis. Myasthenic crisis and cholinergic crisis are two life-threatening complications of myasthenia gravis. Although both conditions result in severe muscle weakness and respiratory distress, the causes and treatments are very different, so it is essential for nurses to recognize the signs quickly. Let's start with myasthenic crisis. This condition occurs when the patient has too little anticholinesterase medication, or when something triggers a sudden worsening of myasthenia gravis, such as infection, emotional stress, surgery, pregnancy, or hot weather. In a myasthenic crisis, the neuromuscular junction simply does not have enough functioning acetylcholine receptors being stimulated, so the muscles become too weak to work properly. As a result, patients may develop ptosis, difficulty swallowing, difficulty speaking, generalized weakness, and shortness of breath. Respiratory muscles fatigue rapidly and the patient may require ventilatory support. This is a medical emergency. Cholinergic crisis, on the other hand, is the result of too much anticholinesterase medication. Instead of not enough acetylcholine stimulation, the body ends up with excessive acetylcholine, overwhelming the receptors that remain. This leads to signs of increased parasympathetic activity, including salivation, lacrimation or tearing, urinary incontinence, diarrhea, gastrointestinal cramping, and emesis. You may also see increased bronchial secretions, sweating, and meiosis, which is constricted or pinpoint pupils. Importantly, muscle weakness also occurs, and this can look very similar to a myasthenic crisis. Because both conditions involve profound weakness and respiratory distress, distinguishing between the two is crucial. A key sign of cholinergic crisis is bradycardia, excessive secretions, and gastrointestinal overactivity, which are not typically present in myasthenic crisis. In both conditions, however, respiratory failure is the major concern, and patients require immediate medical attention. As nurses, recognizing the early signs, identifying medication issues, and notifying the healthcare team promptly can prevent respiratory arrest and save lives. The SLUDGE acronym is a great way to study and learn the hallmark signs and symptoms of a cholinergic crisis. These signs and symptoms occurs when a patient with myasthenia gravis receives too much anticholinesterase medication. The first symptom listed is sweating and salivation, which reflects excessive glandular activity caused by too much acetylcholine. You will see patients drooling, sweating heavily, or complaining of a wet, clammy feeling. Next is lacrimation or tearing. The eyes water continuously, which may also impair vision or cause irritation. Urination increases suddenly, often to the point of incontinence. This is a major clue that the cholinergic system is being overstimulated. Diarrhea and gastrointestinal cramps and pain are also common as the gastrointestinal tract becomes hyperactive, leading to abdominal discomfort, nausea, and hyperperistalsis. Finally, emesis or vomiting often occurs due to excessive GI stimulation. All of these signs together, excessive secretions, cramping, tearing, sweating, form the sludge pattern that nurses must recognize immediately. It's important to remember that in addition to these parasympathetic symptoms, cholinergic crisis also causes increasing muscle weakness, which may look similar to a myasthenic crisis. The difference is that in cholinergic crisis, the weakness is accompanied by these sludge symptoms and sometimes bradycardia, meiosis, pinpoint pupils, and respiratory distress caused by increased bronchial secretions. A cholinergic crisis is a medical emergency because airway obstruction and respiratory failure can occur quickly. As nurses, your role includes recognizing these symptoms early, stopping further doses of anticholinesterase medication, and reporting immediately to the RN or provider so the patient can receive supportive care. Understanding sludge helps you identify the crisis quickly and act promptly to protect the patient's airway and breathing. When diagnosing myasthenia gravis, healthcare providers rely on a combination of patient history, physical assessment, specialized testing, and laboratory studies. Myasthenia gravis does not have a single definitive test, so the diagnosis is usually made by putting together several pieces of clinical evidence. The process begins with a thorough history and physical examination, focusing on symptoms such as fluctuating muscle weakness, ptosis, diplopia, difficulty swallowing, or difficulty speaking. One simple bedside assessment involves asking the patient to maintain an upward gaze for several minutes. In myasthenia gravis, the eyelids gradually droop as the muscles fatigue. Another important diagnostic tool is the measurement of anti-acetylcholine receptor, AChR, antibodies in the blood. These are present in approximately 85–90% of patients with generalized myasthenia gravis. For those who test negative, additional antibody tests such as anti-MuSK antibodies may be used. While these blood tests do not measure severity, they strongly support the diagnosis. Electromyography, or EMG, provides additional data by evaluating the electrical activity of muscles. A specific type called repetitive nerve stimulation looks for a characteristic decrease in muscle response after repeated stimulation, another indicator of myasthenia gravis. Another electromyography method, single-fiber EMG, is even more sensitive and can detect neuromuscular transmission defects even when other tests are normal. Because myasthenia gravis can mimic other neuromuscular disorders, electromyography also helps rule out conditions such as muscular dystrophy or inflammatory myopathies. In some cases, pulmonary function testing is also performed to assess the patient's respiratory muscle strength. This is particularly important for predicting the risk of respiratory compromise or identifying patients at risk for myasthenic crisis. Historically, the Tensilon test was used to differentiate between a myasthenic and a cholinergic crisis. The Tensilon test involved giving a short-acting medication called edrophonium chloride, which briefly increases acetylcholine at the neuromuscular junction. During the Tensilon test, symptoms of a myasthenic crisis typically improve while symptoms of a cholinergic crisis worsen. This opposite response helps clinicians distinguish between the two conditions. Because edrophonium increases acetylcholine, it could cause severe bradycardia, hypotension, bronchospasm, or sudden tightening and narrowing of the bronchi muscles that surround the airways. Laryngospasm, or a sudden tightening of the vocal cords causing temporary blockage of the airway. Respiratory paralysis, and even cardiac arrest, especially in patients already in a cholinergic crisis. These days, many facilities no longer use the Tensilon test due to the risk for sudden parasympathetic overstimulation. Instead, clinical judgment and medication history now guide decision-making. Modern diagnostic methods, antibody testing, EMG, ice pack test, are safer and more accurate. There is currently no cure for myasthenia gravis. Treatment focuses on reducing symptoms, improving muscle strength, and preventing complications such as respiratory failure or myasthenic crisis. Because myasthenia gravis is an autoimmune disorder that affects communication between nerves and muscles, most therapies target either the immune system or the amount of acetylcholine available at the neuromuscular junction. One major intervention is thymectomy, which is the surgical removal of the thymus gland. The thymus plays a large role in the development of the immune system, and in many adults with myasthenia gravis, especially those with thymoma or generalized myasthenia gravis. Removing the thymus can reduce abnormal antibody production. Over time, this can lead to fewer symptoms and in some cases, long-term improvement. Thymectomy is often recommended for patients under age 60 with generalized myasthenia gravis, even if a thymoma is not present. Another category of treatment includes anticholinesterase agents, such as pyridostigmine, mestinon, and neostigmine. These medications work by blocking the enzyme acetylcholinesterase, which normally breaks down acetylcholine. By allowing acetylcholine to stay at the neuromuscular junction longer, muscle contraction improves and patients notice better strength and mobility. These medications help with symptoms, but they do not treat the underlying autoimmune cause of myasthenia gravis. To reduce the immune attack on acetylcholine receptors, patients may also receive steroids and immunosuppressants. Prednisone is commonly used to quickly reduce inflammation and dampen the immune response. Long-term immunosuppressants such as azathioprine, mycophenolate mofetil, or cyclosporine help control the disease and reduce the need for high-dose steroids, which have significant side effects. In certain cases, especially in patients who don't respond to standard therapy, monoclonal antibody medications such as rituximab may be used to target specific immune cells responsible for producing harmful antibodies. For more severe myasthenia gravis or during a crisis, patients may require blood filtering treatment such as plasmapheresis, which physically removes circulating antibodies from the bloodstream. This provides rapid but temporary symptom relief. Similarly, IV immunoglobulin, IVIG, can help by altering immune activity and blocking harmful antibodies. These therapies are often used when a rapid response is needed or when the patient is preparing for surgery, such as thymectomy. Together, these therapeutic interventions allow us to manage myasthenia gravis effectively, prevent exacerbations, and improve quality of life. As nurses, understanding how each treatment works helps us support patients through medication administration, monitoring, education, and early identification of crisis symptoms. When caring for a patient with myasthenia gravis, our nursing priorities focus heavily on activity intolerance, energy conservation, airway protection, and early recognition of crisis. Because myasthenia gravis causes fluctuating muscle weakness that worsens with activity and improves with rest, one of the first steps is to establish the patient's baseline muscle strength. Nurses need to assess which activities cause fatigue, how quickly the muscles weaken, and how well the patient recovers after resting. This helps guide daily care, physical activity plans, and safety precautions. A major part of patient education includes reinforcing education about methods to conserve energy. Patients should space activities throughout the day, take frequent rest breaks, and prioritize tasks when muscle strength is at its highest, typically earlier in the day. Nurses also teach ways to decrease exertion, such as sitting for grooming or using assistive devices. Because myasthenia gravis can worsen suddenly, especially during stress or infection, nurses also reinforce education about how to avoid infections, including good hand hygiene, staying current with vaccines, avoiding people who are ill, and seeking early care for fevers, cough, or urinary symptoms. Another essential teaching point is helping patients recognize early signs and symptoms of a crisis. A myasthenic crisis may present with increased weakness, difficulty swallowing, drooping eyelids, or sudden difficulty breathing. A cholinergic crisis may present with excessive salivation, sweating, diarrhea, bradycardia, and worsening weakness. Informing patients and families how to recognize these symptoms and when to call the provider, or when to seek emergency care, can be life-saving. It's also important to discuss medications to avoid because certain drugs can worsen myasthenia gravis. Some antibiotics, beta blockers, neuromuscular blocking agents used during surgery, and magnesium-containing medications can exacerbate weakness. As nurses, we must always verify medication safety for myasthenia gravis patients. Finally, support systems matter. Myasthenia gravis affects all aspects of daily life, so connecting the patient to a support group, either in person or online, can help with coping, education, and emotional wellness. During the nursing process, it is important to assess the patient's support system, determine whether their needs are being met, and check their understanding of the disease and treatments. We also monitor respiratory function and swallowing ability, because these areas can decline quickly and may require emergency intervention. This comprehensive nursing approach helps improve safety, function, and quality of life for patients with myasthenia gravis. Amyotrophic lateral sclerosis, also known as ALS or Lou Gehrig's disease, is a rapidly progressive and ultimately fatal disorder that affects the motor neurons in the brain and spinal cord. Pathophysiology of amyotrophic lateral sclerosis, ALS. As mentioned, amyotrophic lateral sclerosis is a progressive and degenerative disorder that damages the motor neurons in both the brain and spinal cord. These motor neurons act like communication cables. They send signals from the nervous system to the voluntary muscles of the body. Over time, these neurons begin to deteriorate and die, and as they do, the brain can no longer effectively transmit impulses to the muscles. Once nerve impulse transmission is blocked, the muscles no longer receive the signals needed to contract. As a result, the muscles gradually weaken, begin to waste away, and eventually become paralyzed. This explains why patients experience increasing difficulty with movement, coordination, chewing, swallowing, and eventually breathing as more muscle groups become involved. It is important to remember that amyotrophic lateral sclerosis affects voluntary muscles, not involuntary muscles. This means that the heart, intestines, and other organs controlled by the autonomic nervous system continue to function normally. Amyotrophic lateral sclerosis also does not affect intelligence, memory, or the ability to think clearly. Patients typically remain mentally aware while their physical abilities decline, which can be extremely challenging for both the patient and family. Understanding this progressive loss of motor neurons will help you anticipate patient needs, monitor for complications, and provide supportive and compassionate care as the disease advances. As for the etiology or the causes of amyotrophic lateral sclerosis, one of the most important things to remember is that the exact cause of ALS is still unknown. Most cases are what we call sporadic, meaning they occur without a clear family history or identifiable trigger. Even though the cause is not fully understood, research suggests that ALS may result from a combination of genetic susceptibility, environmental exposures, and cellular dysfunction within the nervous system. A small percentage of amyotrophic lateral sclerosis cases, about 5 to 10%, are familial, meaning they run in families due to specific inherited gene mutations. The most common mutation is in the C9orf72 gene, but several others have been identified. Having a genetic predisposition does not guarantee disease development, but it increases the risk. Environmental factors also appear to play a role. Smoking, exposure to heavy metals, pesticides, industrial chemicals, and possibly military service-related toxins have been associated with higher ALS rates. Repeated physical trauma and intense physical exertion are being studied as potential contributors, but evidence is still evolving. Amyotrophic lateral sclerosis typically begins in adulthood, usually between ages 40 and 70, although it can occur earlier or later. Understanding these risk factors can help you educate patients and families about what we know and what we still don't know about this disease. The signs and symptoms of amyotrophic lateral sclerosis often begin gradually and can be very subtle, which is why early diagnosis can be challenging. The earliest symptoms typically include progressive muscle weakness and atrophy, often starting in the hands, arms, legs, or in the muscles that control speech and swallowing. Muscle weakness occurs because the motor neurons that stimulate voluntary muscles are deteriorating. As muscle fibers lose their nerve supply, they begin to shrink, causing visible atrophy. Patients may also experience muscle fasciculations, which are small, twitching movements under the skin, as well as muscle spasms, which may be painful. As amyotrophic lateral sclerosis progresses, patients develop decreased coordination, making everyday activities like buttoning clothing, writing, or walking more difficult. Because swallowing muscles weaken, patients begin to have difficulty chewing and swallowing, which places them at significant risk for choking and aspiration. Communication also becomes affected. Speech may become slurred or weak and can eventually progress to limited communication, where the patient relies on eye movements or assistive devices. Another seen symptom is emotional lability, or pseudobulbar effect. This is caused by involvement of upper motor neurons and leads to sudden episodes of laughing or crying that do not match the patient's actual emotional state. Throughout the disease, bladder and bowel control usually remain intact, but issues like urgency or constipation can still occur because of reduced mobility and weakened abdominal muscles. As respiratory muscles become progressively weaker, the patient develops pulmonary compromise. This begins with shortness of breath during exertion, then progresses to difficulty breathing while talking, eating, or lying flat. Eventually, the diaphragm and intercostal muscles fail, leading to respiratory insufficiency that often requires mechanical ventilation. In advanced amyotrophic lateral sclerosis, the patient may lose nearly all voluntary motor function, communicating only through blinking or eye-tracking devices. Additional complications can include severe malnutrition, dehydration, pressure injuries, falls, pulmonary embolism, and heart failure. Amyotrophic lateral sclerosis is ultimately fatal, and most patients pass away from respiratory complications, such as pneumonia, atelectasis, or respiratory failure. No single test confirms amyotrophic lateral sclerosis. Diagnosis is based on clinical symptoms and a process of ruling out other neurological disorders. The first step is always a thorough history and physical examination. The provider looks for the hallmark signs, such as progressive muscle weakness, atrophy, fasciculations, and upper and lower motor neuron involvement. Because these symptoms can overlap with other neuromuscular diseases, additional tests are used to exclude other causes. A lumbar puncture with cerebrospinal fluid analysis may be performed. In amyotrophic lateral sclerosis, cerebrospinal fluid findings are typically normal, but this test helps rule out infections, autoimmune diseases, and inflammatory neurological conditions. Sometimes mild increases in protein or enzymes from muscle breakdown may be seen but are not diagnostic. An electroencephalogram, or EEG, is rarely used to diagnose amyotrophic lateral sclerosis directly because ALS does not affect brain waves. However, an electroencephalogram may be ordered if seizures or other cortical abnormalities are suspected, or to help differentiate ALS from other neurological conditions. A nerve biopsy is not routinely needed in amyotrophic lateral sclerosis either, but may be used when there is concern for peripheral nerve diseases such as neuropathies or myopathies. Typically, ALS does not show inflammation or demyelination on biopsy, which helps confirm the degenerative rather than inflammatory nature of the disease. Electromyography, or EMG, is one of the most important tests in the diagnostic process. Electromyography evaluates the electrical activity of muscles and shows characteristic patterns seen in amyotrophic lateral sclerosis, including fibrillations, fasciculations, and evidence of both acute and chronic denervation. A nerve conduction velocity test is often done alongside electromyography to ensure that peripheral nerve damage or demyelinating disorders are not responsible for the patient's symptoms. While blood tests cannot diagnose amyotrophic lateral sclerosis, they may show elevated muscle enzymes such as creatine kinase due to muscle atrophy. These labs help provide supporting evidence but are not specific to ALS. Overall, diagnosis of amyotrophic lateral sclerosis is a careful combination of clinical assessment, exclusion of other conditions, and nerve and muscle testing. Regarding interventions for amyotrophic lateral sclerosis, it's important to remember that ALS is a progressive, fatal neurodegenerative disorder with no known cure. For this reason, all interventions we use as nurses are palliative, meaning they focus on maintaining function, reducing complications, and supporting the patient and family through the disease process. Our priority is to help patients preserve mobility, communication, breathing, and comfort for as long as possible as the motor neurons continue to degenerate. Medications include drugs that either slow the progression of the disease or manage symptoms. Riluzole was the first FDA-approved medication for ALS. It works by reducing the release of glutamate, a neurotransmitter that becomes toxic in excessive amounts and can contribute to motor neuron death. Riluzole does not stop ALS but may extend survival by a few months. Another medication, edaravone, Radicava, helps reduce oxidative stress in neurons, another mechanism thought to accelerate motor neuron degeneration. It has been shown to slow functional decline in some patients. Beyond disease-modifying drugs, many ALS medications focus on symptom management. Glycopyrrolate, Robinol, may be prescribed to reduce excessive oral secretions. Many ALS patients develop drooling because they lose the ability to swallow effectively, not because they produce too much saliva. Drying agents help prevent choking and improve comfort. Carbamazepine or phenytoin can be used for nerve-related pain or muscle cramps. Baclofen is commonly ordered to reduce spasticity, which becomes more prominent as motor neurons die and upper motor neuron pathways become affected. Pain control is also an important consideration. Although amyotrophic lateral sclerosis does not directly cause pain, secondary problems such as muscle cramping, immobility, pressure discomfort, joint pain, and spasticity can significantly affect comfort. Pain must be assessed regularly and treated promptly using both pharmacologic and non-pharmacologic methods. Comfort becomes increasingly important as the disease progresses and mobility declines. Non-pharmacologic and supportive measures become increasingly important as the disease progresses. Because amyotrophic lateral sclerosis causes gradual loss of motor neurons, patients eventually lose voluntary control of mobility, swallowing, speech, and respiratory function. Our nursing focus shifts toward maximizing quality of life, protecting nutrition and airway, preventing complications, and supporting both the patient and family throughout the disease course. These include physical, occupational, and speech therapies. Physical therapy is essential for preserving mobility, preventing contractures, and reducing the risk of falls. Gentle strengthening, stretching, assistive devices, and mobility training help patients remain as independent as possible. Occupational therapy focuses on activities of daily living and maintaining independence. Adaptive equipment such as built-up utensils, dressing tools, and energy conservation techniques may be recommended. Speech therapy is vital because amyotrophic lateral sclerosis affects both speech and swallowing. Therapists work with patients to maintain communication skills and evaluate swallowing safety to reduce the risk of aspiration. Next, there are enteral feedings. As swallowing becomes impaired, patients may lose weight, become malnourished, or experience choking during meals. Many ALS patients eventually require a gastrostomy tube, not because their digestive tract is damaged, but because they can no longer safely chew and swallow enough calories. A percutaneous endoscopic gastrostomy tube, or PEG tube, allows ALS patients to maintain proper nutrition and hydration while reducing the risk of aspiration pneumonia. The decision to place a feeding tube is ideally made early, before respiratory function declines severely. Prevention of infection is another priority. Respiratory infections, especially pneumonia, are a major cause of morbidity and mortality in amyotrophic lateral sclerosis because the respiratory muscles weaken over time. Patients may have difficulty coughing effectively, clearing secretions, or taking deep breaths. Good pulmonary hygiene, suctioning if needed, vaccinations, and early treatment of respiratory symptoms help reduce complications. Skin care is also important since immobility increases the risk of pressure injuries and urinary tract infections. As the disease advances, some patients may require mechanical ventilation to support breathing. This can involve non-invasive ventilation, such as BiPAP, or invasive ventilation through a tracheostomy. These decisions are deeply personal and should be guided by the patient's goals of care. Many patients choose to transition to hospice when breathing becomes difficult, focusing on comfort, symptom relief, and emotional support rather than life-prolonging interventions. Finally, there are augmentative and alternative communication (AAC) interventions. As speech becomes difficult, communication devices such as tablets, speech-generating devices, eye-tracking technology, or symbol boards allow patients to express needs, make decisions, and stay connected with loved ones. Communication support is crucial for maintaining autonomy and dignity, especially in the later stages when speech is significantly impaired. As nurses, our role is to monitor for changes in mobility, nutrition, respiratory function, and communication, prevent complications, coordinate therapy services, and provide compassionate support for both the patient and family. These interventions help ensure safety, comfort, and as much independence as possible throughout the ALS journey. When caring for a patient with amyotrophic lateral sclerosis, nursing interventions focus on supporting both the patient and the family as they manage a progressive neuromuscular disorder that affects mobility, swallowing, and breathing, but does not affect the patient's cognitive ability or reasoning. This is a crucial point. Amyotrophic lateral sclerosis affects the body, not the mind. The patient remains fully aware and mentally intact throughout the disease process, which can create significant emotional challenges. Our care must be compassionate, respectful, and centered on the patient's dignity and autonomy. Reinforcement of patient and family education is a major component of nursing care. We reinforce the information provided by the healthcare provider in simple, understandable terms, and we help the patient and family anticipate changes in function. Support groups can play a powerful role during this process by offering emotional support, coping skills, and connection with others living with amyotrophic lateral sclerosis. Involving the family in care early helps them gain confidence in providing assistance with mobility, communication devices, feeding, positioning, and respiratory support as the disease progresses. Preventing infections is also a key priority because respiratory infections are the leading cause of death in ALS. We remind patients to avoid exposure to individuals who are ill, practice excellent hand hygiene, maintain up-to-date vaccinations, and monitor early signs of infection. As muscle weakness progresses, assistive devices, positioning techniques, and range of motion exercises can help prevent complications such as contractures, pressure injuries, and aspiration. It is also appropriate for nurses to help involve palliative care specialists early in the disease process. They assist with symptom management, advanced directives, and long-term planning while supporting the emotional needs of the patient and family. This holistic approach helps patients maintain the highest possible quality of life as their physical abilities diminish. Above all, we must always remember and must remind the family that the patient's mind stays sharp, aware, and intact, even while the body grows weaker. This understanding should guide all communication and care, ensuring respect, empathy, and patient-centered support. Guillain-Barré syndrome is an acute, rapidly progressive neurological disorder that affects the peripheral nervous system. The pathophysiology of Guillain-Barré syndrome helps us understand why symptoms progress the way they do. Guillain-Barré is an acute inflammatory demyelinating disorder that affects the peripheral nervous system, meaning it impacts nerves outside of the brain and spinal cord. The problem begins when the immune system mistakenly attacks the myelin sheath that surrounds peripheral nerves. Myelin is essential because it allows nerve impulses to travel quickly and smoothly. When it becomes damaged, nerve transmission slows down or stops completely. One of the hallmark patterns of Guillain-Barré is that the demyelination occurs in the peripheral nerves in an ascending fashion. This means symptoms usually begin in the feet and legs and then move upward toward the trunk, arms, and even the cranial nerves. The inflammation you see in this condition is caused by immune cells, particularly lymphocytes and macrophages, which infiltrate the spinal and cranial nerves, leading to edema, compression, and further loss of nerve conduction. As the disease progresses, patients experience progressive weakness, numbness, and diminished or absent deep tendon reflexes. In severe cases, the paralysis can reach the diaphragm and respiratory muscles, which is why some patients require ventilatory support. Although the demyelination happens quickly, remyelination or healing occurs in a descending pattern, meaning strength gradually returns in the reverse order of how it was lost. It's also important to remember that several variants of Guillain-Barré syndrome exist, but the one we focus on in nursing education is the most common form, ascending GBS. This variant follows the classic pattern of symmetrical weakness that starts distally and moves upward. Roughly 17% to 30% of patients may require mechanical ventilation during the acute phase due to respiratory muscle involvement. Early recognition and prompt intervention are critical for preventing complications. As far as the etiology or causes of Guillain-Barré syndrome, one of the most important things for us to understand is that the exact cause is still unknown. What we do know is that Guillain-Barré syndrome is believed to be triggered by an abnormal autoimmune response. The immune system becomes activated after a viral or bacterial infection, or less commonly after a vaccination or surgery, and then mistakenly attacks the peripheral nerves. Most patients report having a respiratory infection, gastrointestinal illness, or flu-like symptoms within about 2 weeks before the onset of neurologic symptoms. The most commonly identified organism linked to Guillain-Barré syndrome is a bacterium called Campylobacter jejuni. This bacterium is one of the leading causes of bacterial gastroenteritis and is often contracted from undercooked poultry or contaminated food or water. Campylobacter infections can cause significant diarrhea, cramping, and fever. For reasons that are still being studied, this organism can trigger an immune reaction that cross-reacts with components of peripheral nerves, a concept called molecular mimicry. Essentially, the immune system becomes confused and thinks the myelin on nerves looks similar to the bacterial proteins, and it begins attacking the nerves as well. It's important to reassure patients and others that Guillain-Barré syndrome is not contagious, and that while infections may trigger it, most people who get these infections do not develop Guillain-Barré syndrome. Understanding these triggers helps us watch for early symptoms in at-risk patients and intervene quickly. There are the 3 clinical stages of Guillain-Barré syndrome, which help us understand how signs and symptoms progress and what we might see as nurses at each point in the disease. Guillain-Barré syndrome almost always follows a predictable pattern, starting with rapid worsening, then a plateau, and then a gradual recovery. Stage 1 is the onset or acute phase, which lasts anywhere from 24 hours up to about 3 weeks. Symptoms begin suddenly and get progressively worse. Patients often describe rapidly increasing weakness that begins in the legs and moves upward, what we call ascending paralysis. They may have difficulty walking, climbing stairs, or even standing. Because the respiratory muscles can be affected, patients may feel short of breath or notice trouble taking a deep breath. During this stage, we must pay close attention to signs of respiratory compromise because this is when ventilatory support may become necessary. The autonomic nervous system can also be involved during stage 1. That means the patient may develop changes in heart rate or blood pressure, urinary retention, constipation or paralytic ileus, or sweating abnormalities. Some patients experience significant neuropathic pain, often described as deep aching, burning, or cramping. Even light touch may feel uncomfortable. Patients are often frightened because the symptoms come on so quickly and they fear losing their ability to breathe. Stage 2 is the plateau phase. This stage usually lasts 2 to 14 days. Weakness has reached its peak and symptoms are at their worst, but they are no longer getting worse. Some patients can feel discouraged during this stage because there is no noticeable improvement yet. The degree of paralysis varies widely. Some patients can still move their arms, while others are fully paralyzed except for the eyes. Respiratory status remains a priority, as the plateau stage is when the need for mechanical ventilation is most common. Stage 3 is the recovery phase. This is when the body slowly begins to repair the damaged nerves. Recovery occurs through axonal regeneration and remyelination, and this is a very gradual process. The recovery stage can last from 6 months up to 2 years. Most patients regain their strength and function, often beginning in the areas affected last and moving downward, the opposite of how symptoms appeared. Many patients return to their previous level of function, but some may be left with mild chronic weakness or sensory changes. The key message for nurses is understanding that the acute phase is the highest risk period, especially for respiratory failure and autonomic instability, while the long recovery phase requires encouragement, therapy, and emotional support. This is a great visual summary of Guillain-Barré syndrome, highlighting the key risks and clinical features in a way that is easier to remember. Let's walk through each component to review. The yellow box lists the risk factors. Guillain-Barré syndrome is most often triggered by an abnormal autoimmune response that occurs after the body fights a viral or gastrointestinal infection. One of the most commonly associated infections is Campylobacter jejuni, a foodborne illness that causes diarrhea. Viral illnesses such as influenza, cytomegalovirus, Epstein-Barr virus, and even COVID-19 have also been linked. The slide also mentions an association with the swine flu immunization. However, it's important to clarify that routine vaccinations today are safe, and the risk of Guillain-Barré syndrome from vaccines is extremely low, much lower than the risk of developing Guillain-Barré syndrome from infections themselves. Guillain-Barré syndrome is most common in adults older than 50, but it can occur at any age. The cartoon of the patient in bed shows that symptoms begin in the lower extremities and ascend upward, which is a hallmark of Guillain-Barré syndrome. Early symptoms include weakness, difficulty walking, and bilateral paresthesia, such as tingling or numbness. As the condition progresses, weakness can spread to the arms, trunk, and face. Some patients develop ataxia or difficulty coordinating movements due to damage to peripheral nerves. The minimal muscle atrophy shown in the picture is accurate. Because Guillain-Barré syndrome progresses rapidly, there usually isn't time for significant muscle wasting early on. The notes on the right side highlight that Guillain-Barré syndrome causes symmetrical paralysis, meaning it affects both sides of the body equally. As paralysis reaches the chest muscles, the patient may have trouble breathing, talking, or swallowing. The autonomic nervous system may also be affected, leading to bowel and bladder dysfunction, heart rate irregularities, or blood pressure swings. This is why close monitoring in the hospital is essential. The ventilator image symbolizes the possibility of needing respiratory support. About 17% to 30% of Guillain-Barré syndrome patients develop respiratory failure requiring intubation and mechanical ventilation. This is most likely to occur during the first 2 weeks when symptoms are rapidly progressing. This image is meant to reinforce that Guillain-Barré syndrome is a medical emergency that requires prompt recognition, ongoing respiratory assessment, and close monitoring of neurological status. There are important signs and symptoms that occur with Guillain-Barré syndrome that are important to recognize. These signs and symptoms lead to complications that occur because GBS causes rapid ascending weakness that can affect both the respiratory muscles and the autonomic nervous system. Understanding these complications is critical because early recognition can be life-saving. One of the most serious complications is respiratory failure. As weakness ascends from the legs to the chest, the muscles responsible for breathing, such as the diaphragm and intercostal muscles, become weak. Patients may start to breathe shallowly or rapidly, they may feel short of breath, or they may have difficulty speaking in full sentences. It is important to remember that GBS is a medical emergency when respiratory weakness begins. These patients require close monitoring of oxygen saturation, respiratory effort, lung expansion, and the ability to clear secretions. Many will require intubation early, often within the first week of symptoms. The key difference from other neuromuscular disorders is that GBS patients are expected to recover, making early respiratory support especially important. Next, these patients are at high risk for infection. Because of immobility and weakened cough effort, they may not clear their airway well, which increases the chance of pneumonia. Urinary retention or use of urinary catheters may lead to urinary tract infections. Maintaining strict infection control practices, turning the patient frequently, suctioning as needed, and providing good hydration and nutrition all help reduce infection risk. Depression is also common. GBS symptoms appear suddenly, and patients can quickly lose mobility, speech, or the ability to breathe independently. This emotional shock can greatly affect coping, provide reassurance, encourage communication with family, and collaborate with the interdisciplinary team to support mental health. The slide also highlights complications of immobility. When patients cannot move well, they are at risk for pressure injuries, deep vein thrombosis, muscle atrophy, constipation, and pulmonary emboli. Nurses play a major role in preventing these complications through frequent repositioning, skin inspection, range of motion exercises, hydration, and use of compression devices. Patients often fear that they will not recover function. It is important to support them with calm, honest reassurance. Recovery is slow but expected, especially with good supportive care. Because Guillain-Barré syndrome progresses quickly and can lead to respiratory failure, early and accurate diagnosis is essential. These tests help the healthcare team confirm the condition and determine how severe the nerve involvement is. The first test listed is a lumbar puncture, often called a spinal tap. During this procedure, cerebrospinal fluid is collected from the lower back. In patients with Guillain-Barré syndrome, cerebrospinal fluid results typically show what is called albuminocytologic dissociation. This means the protein level in the cerebrospinal fluid is elevated, while the white blood cell count remains normal. This pattern reflects inflammation and damage to the myelin without infection. It usually appears after the first week of symptoms. Next, we have electromyography, or EMG. This test measures the electrical activity in muscles and how well the nerves are communicating with them. In Guillain-Barré syndrome, the conduction between the nerve and muscle becomes slower or blocked because myelin is damaged. Electromyography helps confirm that the weakness is coming from a peripheral nerve problem rather than from the brain or spinal cord. A related test is nerve conduction velocity, or NCV. This test uses small electrical impulses to measure how fast signals travel along the nerves. In Guillain-Barré syndrome, nerve conduction is typically slowed, which supports the diagnosis of a demyelinating disorder. Finally, we look at pulmonary function testing. This is extremely important because respiratory failure is one of the most serious complications of Guillain-Barré syndrome. These tests measure lung capacity and the patient's ability to take deep breaths. A declining vital capacity or difficulty clearing secretions can be a sign that the patient is approaching respiratory failure. Early detection helps the team determine when intubation or mechanical ventilation may be needed. Overall, these diagnostic tools help clinicians confirm Guillain-Barré syndrome, rule out other causes of paralysis, and guide critical care decisions. As nurses, your role includes preparing patients for testing, monitoring them afterward, and documenting changes in respiratory or neuromuscular status. Early treatment and vigilant nursing care are essential for Guillain-Barré syndrome because it can progress so quickly. One of the primary treatments is plasmapheresis, also called plasma exchange. Just as in cases of multiple sclerosis and myasthenia gravis, plasmapheresis therapy removes the plasma from patients with Guillain-Barré syndrome because the IT contains harmful antibodies, and removing the harmful antibodies can help shorten the course of the disease and reduce symptom severity. The removed plasma is replaced with donor plasma, or albumin. Another first-line treatment is intravenous immunoglobulin therapy, or IVIG, which works by modifying the body's immune response. Please note that plasmapheresis and IVIG are never given together, but both are considered equally effective. Patients often require oxygen therapy, especially if their breathing muscles are becoming weak. As the disease progresses, about 1/4 of patients will require mechanical ventilation due to respiratory failure. Early identification of respiratory decline is crucial, and nurses play a key role in monitoring vital capacity, breath sounds, and the ability to clear secretions. Guillain-Barré syndrome is frightening for patients because paralysis can happen quickly, and they often remain mentally alert while their physical abilities decline. Providing emotional support is just as important as physical care. Patients may feel anxious, helpless, or fearful about losing independence and the possibility of needing intubation. Calm reassurance, education, and involving family members in care can help reduce emotional distress. Because patients are immobile for long periods, anticoagulants are commonly prescribed to prevent deep vein thrombosis. Immobility also puts them at risk for skin breakdown, atelectasis, pneumonia, and urinary infections. Pain can be significant due to nerve inflammation, so analgesics are essential for comfort and to support early rehabilitation. Finally, rehabilitation becomes a major part of recovery. As paralysis improves, patients may require months of physical, occupational, and speech therapy to regain strength and function. Recovery can take 6 to 24 months. Nurses should encourage gradual activity, maintain motivation, and coordinate with rehabilitation specialists. Overall, care for Guillain-Barré syndrome is comprehensive and requires a combination of medical treatment, respiratory support, emotional support, and long-term rehabilitation. Post-polio syndrome is a condition that affects individuals who previously had poliomyelitis, commonly known as polio. Pathophysiology and etiology of post-polio syndrome. Post-polio syndrome is a late complication seen in people who previously had poliomyelitis. Post-polio syndrome typically develops 10 to 40 years after the initial infection. During the original polio illness, many motor neurons were destroyed. The remaining neurons compensated by expanding and taking on additional workload to help the patient regain muscle function. Over time, these overworked neurons begin to deteriorate, leading to the new onset of muscle weakness and fatigue. This decline is not caused by a new viral infection. It is the result of long-term stress on the surviving motor neurons. Common symptoms include progressive muscle weakness, severe fatigue, musculoskeletal pain, and sometimes respiratory compromise if the muscles involved in breathing were affected during the original polio infection. Some individuals also experience sleep problems, joint pain, or posture changes such as scoliosis because weakened muscles are unable to support the body effectively. Treatment is supportive, with rest and energy conservation being essential aspects of care. Patients must learn to balance activity with frequent rest periods to prevent overworking the remaining motor units. As nurses, we play an important role in helping patients pace their activities, recognize signs of overexertion, and understand that their symptoms are a long-term consequence of previous polio, not a recurrence of infection. These images offer visual representation of how post-polio syndrome manifests. In the image on the left, we see a person with asymmetric muscle wasting, which is one of the hallmarks of post-polio syndrome. Polio rarely affects both sides of the body equally. You can see that there is a noticeable reduction in muscle bulk in the right upper body and shoulder area compared with the other side. This type of asymmetry helps you differentiate post-polio syndrome from systemic neuromuscular diseases that cause more generalized weakness. On the right, we see a close-up of the lower extremities. Again, what stands out is uneven muscle mass, particularly in the calves. The affected limb may appear thinner, weaker, or smaller because of long-term denervation and muscle fiber loss. Some patients may also develop joint deformities, contractures, or changes in gait because they rely heavily on stronger muscles to compensate for weaker ones. Clinically, patients often report new fatigue, pain, shortness of breath, and decreased endurance that gradually worsen. The nurse's role is to monitor mobility changes, support safe ambulation, and encourage energy conservation techniques. These patients benefit from low-impact, non-fatiguing exercise, assistive devices, and pacing activities to prevent overuse of weakened muscle groups. It's important to remember that people with post-polio syndrome are at higher risk for falls, respiratory complications if respiratory muscles were involved, and progressive loss of independence. Our nursing care focuses on safety, mobility support, pain control, and teaching patients how to prevent muscle overuse while maintaining as much function as possible. Pain, and sometimes respiratory compromise if the muscles involved in breathing were affected during the original polio infection. Some individuals also experience sleep problems, joint pain, or posture changes such as scoliosis because weakened muscles are unable to support the body effectively. Treatment is supportive, with rest and energy conservation being essential aspects of care. Patients must learn to balance activity with frequent rest periods to prevent overworking the remaining motor units. As nurses, we play an important role in helping patients pace their activities, recognize signs of overexertion, and understand that their symptoms are a long-term consequence of previous polio, not a recurrence of infection. These images offer visual representation of how post-polio syndrome manifests. In the image on the left, we see a person with asymmetric muscle wasting, which is one of the hallmarks of post-polio syndrome. Polio rarely affects both sides of the body equally. You can see that there is a noticeable reduction in muscle bulk in the right upper body and shoulder area compared with the other side. This type of asymmetry helps you differentiate post-polio syndrome from systemic neuromuscular diseases that cause more generalized weakness. On the right, we see a close-up of the lower extremities. Again, what stands out is uneven muscle mass, particularly in the calves. The affected limb may appear thinner, weaker, or smaller because of long-term denervation and muscle fiber loss. Some patients may also develop joint deformities, contractures, or changes in gait because they rely heavily on stronger muscles to compensate for weaker ones. Clinically, patients often report new fatigue, pain, shortness of breath, and decreased endurance that gradually worsen. The nurse's role is to monitor mobility changes, support safe ambulation, and encourage energy conservation techniques. These patients benefit from low-impact, non-fatiguing exercise, assistive devices, and pacing activities to prevent overuse of weakened muscle groups. It's important to remember that people with post-polio syndrome are at higher risk for falls, respiratory complications if respiratory muscles were involved, and progressive loss of independence. Our nursing care focuses on safety, mobility support, pain control, and teaching patients how to prevent muscle overuse while maintaining as much function as possible. Diagnosis of post-polio syndrome is primarily clinical. This means it relies heavily on a careful patient history and a thorough physical examination. The provider will ask about the patient's original polio infection, their functional status after recovery, and when new symptoms such as fatigue, muscle weakness, or pain began to appear. Post-polio syndrome is considered a diagnosis of exclusion, meaning that the clinician must first rule out other medical conditions that may mimic these symptoms, such as arthritis, neuropathy, muscular dystrophy, hypothyroidism, or chronic fatigue syndrome. Basic blood work, imaging studies, nerve conduction tests, or electromyography may be used to eliminate other causes, but these tests do not confirm post-polio syndrome. For nurses, the most important role in diagnostics is recognizing symptom patterns, documenting changes in function, and reporting concerns promptly. Many patients feel frustrated because symptoms return decades after they believed they had recovered. Providing reassurance, clear explanations, and emotional support is essential in helping patients cope with this lifelong condition. Post-polio syndrome interventions. IT is important to emphasize that there is currently no known cure and no treatment that can halt the progression of the condition. Instead, nursing care focuses on reducing symptoms, improving functional ability, and helping patients conserve their limited energy. Many patients experience new muscle weakness decades after their initial polio infection because the motor neurons that compensated for the earlier damage slowly lose their ability to maintain the extra workload. Physical therapy must be gentle and carefully structured to avoid overuse because excessive exercise can actually worsen muscle fatigue and weakness in these patients. Therapists typically focus on low-intensity strengthening, stretching, and aquatic therapy, which reduce strain while improving mobility. Occupational therapy plays a significant role in helping patients adjust their daily routines by teaching energy conservation techniques such as pacing, planning rest periods, using adaptive tools, and reorganizing home activities to reduce physical stress. Assistive devices, including braces, canes, walkers, scooters, or orthotics, may be recommended to improve safety and prevent falls. Nurses should remind patients that pushing through fatigue can lead to long-term decline, so respecting limits is part of the treatment. Because chronic pain is common, nurses monitor discomfort and collaborate with providers on individualized approaches such as heat therapy, NSAIDs, or supportive bracing. Overall, nursing care centers on helping the patient maintain the best possible quality of life while preventing further muscle strain and promoting safe mobility. Restless leg syndrome, RLS, is an uncomfortable sensation in the legs, usually described by patients as tingling, crawling, pulling, or burning. It also causes an urge to move the legs in order to relieve the discomfort. Restless leg syndrome is a neurological sensory disorder that creates this irresistible urge to move the legs, usually accompanied by uncomfortable sensations as mentioned, such as tingling, crawling, burning, itching, or deep aching. These symptoms occur most often at rest or at night and can significantly disrupt sleep. The disorder is thought to be linked to an imbalance of dopamine and serotonin in the brain, both neurotransmitters that help regulate movement and sensory processing. Restless leg syndrome can also have a hereditary component, especially when symptoms begin before age 40. Several medical conditions can increase the risk, including chronic kidney disease, iron deficiency, diabetes, Parkinson's disease, and peripheral neuropathy. Certain medications, such as antihistamines, antidepressants, and antipsychotics, may worsen symptoms. Symptoms often improve when underlying medical issues are corrected or when offending medications are discontinued. As nurses, it is important to collect a detailed sleep history, assess nighttime symptoms, monitor iron levels, and provide patient education about sleep hygiene and lifestyle changes that may lessen symptoms. The signs and symptoms of restless leg syndrome are defined by unpleasant sensations in the legs that occur during rest, most often in the evening or during sleep. Patients may describe these sensations as creeping, crawling, throbbing, pulling, or feeling like pins and needles. These sensations create an overwhelming urge to move the legs in order to relieve the discomfort. Movement, such as walking, stretching, or shaking the legs, provides temporary relief, but the symptoms come back when the patient tries to rest again. Because symptoms worsen at night, patients often struggle with falling asleep or staying asleep, which may lead to daytime fatigue, poor concentration, irritability, and reduced work or academic performance. Over time, chronic sleep loss can affect mood and limit the patient's ability to complete activities of daily living. Restless leg syndrome can affect both men and women of all ages, but women experience it almost twice as often as men. Many patients delay reporting symptoms because they believe they will not be taken seriously, or they assume the sensations are normal. As nurses, it's important that we validate the patient's experience and ensure that symptoms are addressed so the patient can receive proper evaluation and treatment. There are no specific diagnostic tests that confirm restless leg syndrome. Instead, diagnosis is based heavily on the patient's history, their reported sensations, and how those symptoms behave over time. Please note that the symptoms of restless leg syndrome typically worsen during periods of rest or inactivity, especially in the evening or at night, and that movement provides temporary relief. These features are crucial for identifying restless leg syndrome in clinical practice. When assessing a patient, we begin by talking with them about their sleep history. Poor sleep, difficulty falling asleep, frequent nighttime awakenings, or chronic fatigue during the day may indicate that symptoms are disrupting the patient's sleep cycle. Sleep disruption is one of the biggest functional impacts of restless leg syndrome and a major reason patients finally seek medical attention. Because iron deficiency is a well-known contributor to restless leg syndrome, the healthcare provider may order a laboratory test to check ferritin and iron levels. Even if anemia is not present, low ferritin alone can worsen restless leg syndrome, so this lab value is especially important. Treating iron deficiency often improves symptoms significantly. A review of the patient's medication history is also important. Certain medications, such as antihistamines, some antidepressants, dopamine-blocking medications, and even caffeine, can worsen or trigger symptoms. Family history should also be explored, as restless leg syndrome can have a genetic component. Overall, the diagnosis comes from a combination of the patient's symptom description, sleep patterns, medical history, and laboratory evaluation, particularly iron studies. Ruling out other conditions such as neuropathy, nocturnal leg cramps, arthritis, or vascular issues is also essential to avoid misdiagnosis. The primary goal of treatment for restless leg syndrome is symptom reduction and improvement in sleep quality. Restless leg syndrome does not have a cure, so our interventions focus on lifestyle adjustments, symptomatic relief, and medication when needed. Many patients find that simple physical measures such as applying heat or cold packs, massaging the legs, or taking warm baths before bedtime help reduce the uncomfortable sensations. These non-pharmacologic methods can relax muscle tension, increase circulation, and decrease nerve irritation that contributes to symptoms. In addition to comfort strategies, medications can be used when symptoms are moderate to severe or when they disrupt sleep. Dopamine agonists such as pramipexole, Mirapex, Ropinirole, Requip, or rotigotine, Nupro, patches, are first-line treatments because restless leg syndrome is linked to dopaminergic dysfunction in the brain. These medications help regulate dopamine levels and reduce the urge to move the legs. However, they must be used carefully because long-term use can lead to augmentation, where symptoms become more severe or start earlier in the day. Lifestyle modifications are equally important in managing restless leg syndrome. Encouraging the patient to avoid caffeine, alcohol, and nicotine can significantly reduce nighttime symptoms because these substances can worsen nerve irritation or disrupt sleep patterns. Regular sleep schedules and moderate daily exercise support the body's natural circadian rhythm and help reduce nighttime restlessness. Education is essential. Patients should understand that even small changes in their daily habits can make a meaningful difference in symptom control. Finally, some patients benefit from additional treatments such as low-dose opioids, anticonvulsants, or benzodiazepines when first-line therapies fail, but these are used cautiously due to safety concerns. The nurse's role includes monitoring patient response, assessing for side effects, reinforcing lifestyle strategies, and helping patients understand the importance of establishing healthy sleep routines. Nursing care for patients with restless leg syndrome focuses on patient education. Patients often struggle with symptoms for years before receiving a diagnosis, so clear, supportive teaching makes a significant difference. I start by explaining lifestyle changes that can reduce symptoms such as limiting caffeine, alcohol, and nicotine, maintaining a consistent sleep routine, and incorporating regular moderate exercise. These strategies help decrease nighttime discomfort and improve sleep quality. Next, review the patient's current medications because many drugs, including antihistamines, antipsychotics, some antidepressants, and certain anti-nausea medications, can worsen RLS symptoms. It is important to teach patients not to discontinue medications independently, but to discuss any concerns with their provider. It is important to explore the patient's sleep history, asking about sleep onset, nighttime awakenings, use of sleep aids, and daytime fatigue. RLS often leads to sleep deprivation, which increases irritability, worsens concentration, and affects functional ability. A thorough sleep assessment helps guide the plan of care. Finally, if symptoms are severe, persistent, or significantly impairing sleep, a referral to a sleep specialist may be appropriate. Sleep medicine providers can order formal sleep studies, adjust medications, or explore additional therapies when standard interventions are not effective. Overall, nursing care emphasizes patient empowerment, symptom tracking, safe medication use, and appropriate referrals to promote better rest and improved quality of life. As we transition into cranial nerve disorder, remember that cranial nerves are actually part of the peripheral nervous system. There are 12 pairs of cranial nerves, and each one has a very specific job. Some control sensory functions like smell and vision, others control movement of the face, eyes, tongue, and shoulders, and some do a combination of both. Peripheral neuropathies occur when these cranial nerves become damaged or inflamed. This can interrupt communication between the brain and the body, leading to problems such as pain, weakness, numbness, or loss of function in the area served by that nerve. Causes of cranial nerve neuropathies vary. They can include viral infections, such as herpes simplex or varicella zoster, bacterial infections like Lyme disease, tumors, which can compress the nerve, trauma, as seen with head injuries, or unknown causes, which we often refer to as idiopathic cases. Two of the most common cranial nerve neuropathies you will see in clinical practice are trigeminal neuralgia, which causes severe facial pain, and Bell's palsy, which leads to one-sided facial paralysis. We'll look at both in more detail in the following slides. The nurse's role is to monitor for cranial nerve deficits, identify changes in speech, swallowing, vision, or facial movement, and promptly report these findings. Early recognition can significantly improve outcomes for patients with neuropathies. Trigeminal neuralgia, which is one of the most well-known cranial nerve disorders. It affects the fifth cranial nerve, also known as the trigeminal nerve, which is responsible for sensation in the face and motor function for chewing. Trigeminal neuralgia is also known as tic douloureux. As mentioned, it involves the fifth cranial nerve, which has three major sensory branches that supply the forehead, cheeks, jaw, teeth, gums, and part of the scalp. The disorder occurs when this nerve becomes irritated or compressed, causing episodes of sudden, severe facial pain. From a pathophysiology standpoint, the trigeminal nerve becomes hyperexcitable, meaning it fires pain signals in response to minimal or even no stimulation. The most common mechanism behind this is vascular compression, where a small artery or vein presses against the nerve root as it exits the brainstem. This compression gradually erodes the nerve's protective myelin sheath, leaving the nerve exposed and easily triggered. The sensory portion, the part responsible for feeling sensations in the face, is the most affected, which is why patients experience sharp electric shock-like facial pain. Etiology, or causes of trigeminal neuralgia, can include chronic pressure from blood vessels, tumors, cysts, or structural abnormalities, but the majority of cases are caused by idiopathic vascular compression, meaning the exact cause is unknown but believed to be related to age-related changes. Some cases are linked to conditions that damage myelin, such as multiple sclerosis. Irritation or chronic compression results in unpredictable, intense pain episodes that often interfere with speaking, eating, and daily activities. The condition is most common in women and typically begins after age 50. Trigeminal neuralgia is considered one of the most painful conditions involving the cranial nerves. The hallmark symptom is sudden, severe stabbing pain that occurs on one side of the face. Patients often describe it as a jolting, shock-like, or electric pain that comes out of nowhere. The pain typically affects the areas innervated by the trigeminal nerve: the forehead, cheek, nose, lips, gums, jaw, or chin, depending on the branch involved. Even though the nerve has both sensory and motor fibers, trigeminal neuralgia affects the sensory portion almost exclusively. Attacks are usually triggered by very light stimulation, even things that wouldn't usually be painful. Examples include touching the face, speaking, chewing, brushing teeth, washing the face, putting on makeup, cold air, or even smiling. These areas are known as trigger zones. Because of how unpredictable the attacks are, patients may become fearful of doing normal daily activities. Episodes last seconds to minutes, but they may cluster together many times a day. Sleep often helps interrupt the pain cycle, so you may see patients who lie still or nap frequently to avoid triggering an attack. Over time, this can affect nutrition, hygiene, communication, and emotional well-being. Trigeminal neuralgia does not have a single definitive lab test. Diagnosis is mainly clinical, meaning it relies heavily on the patient's description of symptoms and the provider's assessment. Diagnosis begins with the history and physical examination. This is the most important part. We listen for classic pain features associated with trigeminal neuralgia: sudden electric shock sensations occurring on one side of the face, often triggered by talking, chewing, or light touch. The physical exam helps rule out other causes of facial pain, such as dental issues, sinus problems, or cluster headaches. Next, patients may undergo CT scanning. A CT scan helps identify structural problems, such as tumors, facial bone abnormalities, or injuries, but it is less sensitive for the cranial nerves themselves. The MRI is the preferred imaging study. MRI can detect blood vessels that may be compressing the trigeminal nerve, inflammation, tumors, or signs of multiple sclerosis. Remember, multiple sclerosis is one of the known causes of secondary trigeminal neuralgia. MRI is especially important for patients who are younger, have atypical symptoms, or have sensory loss, because we need to make sure nothing else is contributing to the nerve irritation. Overall, diagnosis is made through a combination of the patient's symptom history, direct observation during an attack, and imaging, especially MRI, to rule out underlying pathology. The overall goal of therapy for trigeminal neuralgia is to reduce the frequency and severity of these pain episodes by calming down the irritated trigeminal nerve or blocking its pain signals when needed. Let's begin with anticonvulsants, which are the first-line treatment. Medications such as carbamazepine, also known as Tegretol, and oxcarbazepine, known as Oxtellar XR or Trileptal, help stabilize nerve membranes and reduce the abnormal firing of the trigeminal nerve. These medications are more effective than opioids because trigeminal neuralgia pain is neuropathic, not inflammatory. It's important to monitor patients for side effects such as dizziness, drowsiness, hyponatremia, or bone marrow suppression with carbamazepine. Nurses must notify the RN or provider if the patient reports fever, sore throat, or rash, which can indicate serious medication reactions. If medications are not effective or tolerated, the next option is nerve blocks. These involve injecting numbing agents or other medications directly near the trigeminal nerve to interrupt pain transmission. Relief may be temporary, lasting from days to months, but can help patients regain function and improve quality of life. As the nurse, you will help the patient understand what to expect, monitor for facial numbness, and teach safety precautions after the procedure to prevent accidental injury. When pain remains severe despite other treatments, patients may be candidates for surgery to block pain signals. One of the most common procedures is microvascular decompression, where a surgeon moves or pads a blood vessel that's pressing on the nerve root. Other procedures include radiofrequency ablation, gamma knife radiation, and glycerol injections, which intentionally damage parts of the nerve to decrease pain transmission. The downside is that these can leave the patient with facial numbness or altered sensation, so we must teach protective strategies. After any procedure that causes numbness, the patient must protect the anesthetized area of the face. If the corneal reflex is weakened, the patient may not feel irritation in the eye, so protective goggles or sunglasses may be necessary. At night, an eye patch may be needed to prevent injury or dryness. Some patients may require artificial tears to prevent corneal damage. Nurse care focuses on safety, pain monitoring, medication administration, and teaching the patient how to prevent injury while living with decreased facial sensation. Bell palsy. Bell palsy is an acute unilateral paralysis of the facial nerve, cranial nerve 7. Remember, cranial nerve 7, the facial nerve, controls facial expressions, eyelid closure, taste on the anterior tongue, tear production, and parts of salivation. When it becomes inflamed or swollen, it can no longer transmit normal motor signals, which leads to weakness or total paralysis on one side of the face. Because Bell palsy is an acute unilateral paralysis of the facial nerve or cranial nerve 7, understanding the function of the facial nerve helps us better understand Bell palsy. The pathophysiology of Bell palsy is linked to inflammation and edema of the facial nerve. This swelling usually occurs in the narrow bony canal that the nerve travels through. Because the nerve is trapped in that small space, even a small amount of swelling can compress it, leading to loss of motor control, drooping of facial features, difficulty closing the eye, and impaired facial movement. Many patients first notice symptoms when they try to smile, blink, or raise an eyebrow and only one side of the face moves. The etiology of Bell palsy is unknown. Researchers believe Bell palsy may be triggered by viral infections, especially herpes simplex virus type 1, HSV1. Other possible triggers include varicella zoster virus, Epstein-Barr virus, influenza, and even recent upper respiratory infections. However, because no single cause is consistently found, the official etiology remains classified as idiopathic. It's important to emphasize that Bell palsy is not a stroke, even though it can appear similar to patients and families. Unlike stroke, Bell palsy usually affects both the upper and lower parts of one side of the face and does not involve arm or leg weakness, speech difficulty, or cognitive changes. Nursing priorities for Bell palsy include eye protection, maintaining oral hygiene, supporting eating and drinking, reducing anxiety, and helping the patient adjust to temporary facial asymmetry. Most patients recover completely, especially with early treatment, but emotional support and patient education play an important role during the recovery phase. The signs and symptoms of Bell palsy typically develop suddenly or may progress over 2 to 5 days. One of the earliest and most important signs to look for is one-sided facial weakness or paralysis. Patients may describe a sudden heaviness, tightness, or numb sensation on one side of the face. Pain behind the ear is also a common early warning sign that may appear before visible weakness develops. This slide highlights several key symptoms. First is pain, which may occur around the ear or jaw and is sometimes described as aching or discomfort rather than sharp pain. Next is weakness, which results from impaired nerve signals to the muscles of facial expression. This weakness causes the classic facial drooping you see in the image. The affected side of the forehead cannot wrinkle, the eyebrow does not lift, and the eyelid may not close completely, which puts the eye at risk of dryness and injury. Speech difficulty may occur because facial paralysis affects the lips, cheeks, and mouth muscles needed to form certain sounds. Patients may also experience drooling, especially when drinking, because they cannot maintain lip closure. Another common symptom is excess tearing, also called epiphora, because the eyelid does not close properly. The tear film cannot be spread across the eye, leading to constant tearing. One of the hallmark symptoms is the inability to blink or fully close the eye, known as lagophthalmos. This puts the cornea at high risk for dryness, abrasions, and ulceration. As nurses, you must prioritize eye protection and ensure that patients use lubricating drops, ointments, or eye patches as needed. In addition to the symptoms shown on the slide, patients may also lose the sense of taste on the anterior 2/3 of the tongue due to the facial nerve's sensory branch. The onset can be frightening for patients because the facial drooping may resemble a stroke. Your role is to help differentiate symptoms, provide reassurance, and ensure timely evaluation and supportive care. Most patients recover fully within 6 months, but early treatment and appropriate nursing interventions help prevent complications and promote healing. This is a great visual summary of Bell's palsy that illustrates the hallmark symptoms you should expect to see during a patient assessment. Let's review. Bell's palsy is a temporary paralysis of the facial nerve, cranial nerve 7. It typically occurs on one side of the face and comes on suddenly, often overnight. Because the facial nerve controls eyelid closure, blinking, smiling, and the forehead muscles, the symptoms become very noticeable. One of the key features is that the forehead does not wrinkle on the affected side. This helps you differentiate Bell's palsy from a stroke, because in a stroke, the forehead usually can still wrinkle. With Bell's palsy, the eyelid doesn't close completely. The eye may roll upward when the patient tries to blink, and they may have tearing or drying of the eye because it can't close properly. You'll also see drooping of the mouth and a flat nasolabial fold. Patients may have trouble smiling, speaking clearly, or keeping fluids from leaking from the mouth. Pain behind the ear is a common early complaint. The cartoon highlights a suspected cause, possible reactivation of the herpes simplex virus. This is one of the strongest theories, but the exact cause is still not fully understood. Other viral triggers may also play a role. Treatment focuses on reducing inflammation of the facial nerve. That's why corticosteroids, such as prednisone, are the first-line therapy and work best when started within 72 hours of onset. Antivirals may be added when a viral cause is suspected, but their effectiveness varies. Most patients recover fully within 6 months, especially when treatment begins right away. As nurses, main priorities include protecting the eye because incomplete eyelid closure puts the patient at risk for corneal injury. Lubricating drops may be applied during the day and ointment at night. The provider may recommend taping the eye closed during sleep. Education and reassurance are important because the symptoms can be frightening, but the prognosis is typically very good. Bell's palsy is primarily a clinical diagnosis, meaning that the patient's history and physical exam provide the strongest clues. Please note that the onset of symptoms is usually sudden, often occurring over hours. During the assessment, facial asymmetry is assessed, such as the patient's ability to close the eye, wrinkle the forehead, and smile. A hallmark sign that supports Bell's palsy over a stroke is the inability to wrinkle the forehead because the facial nerve is affected peripherally. An electromyography may be used to measure electrical activity of facial muscles. It can help determine the severity of nerve involvement, especially when symptoms are prolonged. However, electromyography is not always required and may not be immediately available in all clinical settings. A critical part of diagnosing Bell's palsy is ruling out a stroke, since both can present with facial drooping. The difference is that stroke typically affects only the lower part of the face, meaning the patient may still be able to wrinkle the forehead or close the eye. If stroke symptoms are suspected, like limb weakness, slurred speech, or confusion, emergency evaluation is required. Overall, the diagnostic process for Bell's palsy depends heavily on patient history, symptom onset, and ruling out other serious conditions. For Bell palsy, the overall goal of treatment is to reduce inflammation, promote nerve recovery, and prevent complications, especially those involving the eye and facial muscles. Most cases of Bell palsy improve significantly within weeks, but early treatment increases the chances of a full recovery. The first intervention listed is prednisone, a corticosteroid. Prednisone is considered the first-line treatment and is most effective when started within 72 hours of symptom onset. It works by reducing inflammation and edema in the facial nerve as it travels through the narrow facial canal. This decreases nerve compression and helps restore normal motor function. Treatment typically lasts about 7 to 10 days, often starting with a higher dose and tapering down. Next are analgesics, which help manage discomfort. Although Bell palsy is primarily a motor nerve condition, many patients experience ear pain or facial soreness. Analgesics do not treat the paralysis itself but help improve comfort, especially in the early stages when inflammation is high. Antiviral medications such as acyclovir or valacyclovir may be used in combination with prednisone, particularly in cases where a viral cause is suspected, such as herpes simplex virus or varicella zoster virus. While antivirals alone are not consistently effective, research shows a slight improvement in recovery when they are combined with steroids in severe cases. Moist heat is another supportive treatment. Applying warm compresses to the affected side of the face can help reduce pain and promote circulation. Make sure compresses are warm, not hot, to prevent burns, especially since patients may have reduced sensation. Gentle massage of the face and ear area may provide comfort and stimulate circulation. Massage should be light and performed only if tolerated. In later stages, massage may also reduce muscle stiffness or help prevent contractures. Finally, a facial sling may be used for patients with significant drooping. This simple support device helps reposition the mouth and cheek during eating or speaking and can improve oral control and comfort. It does not treat the underlying nerve inflammation but helps maintain functional symmetry while the nerve recovers. The primary goal of nursing care is to protect the patient's airway, eye, nutrition, and facial function while supporting comfort and recovery. Nursing care of Bell palsy also prioritizes monitoring the patient's pain. Bell palsy pain is often described as sharp, aching, or located behind the ear. Nurses need to assess where the pain is, how severe it is, what triggers it, what the patient has used for relief, and how the pain affects daily function. Document your findings thoroughly. Because Bell palsy affects cranial nerve 7, patients are also at risk for complications, especially aspiration if facial weakness affects their ability to chew or swallow. Nurses should monitor for warning signs like a wet, gurgling voice after meals, coughing or choking during eating, pocketing food in the cheek, delayed swallowing, or drooling. Another major risk is eye injury because many patients cannot fully close the affected eyelid. This puts them at risk for drying, corneal abrasions, and infection. Interventions include lubricating eye drops, ointments, safety glasses during the day, and taping the eyelid closed at night. Nurses collaborate with the healthcare provider, speech therapist, and dietitian as needed. Speech therapy can evaluate swallowing risks, and nutrition support may be helpful if eating becomes difficult. Throughout care, nurses also reinforce education to the patient about protecting the affected side of the face, using artificial tears, chewing on the unaffected side, and monitoring symptoms that worsen or fail to improve. This concludes the presentation. Thank you.